Welcome to Pathology Central Key Concepts. The topic of this video is clinical aspects of neoplasia. So you've probably noticed that there are a number of videos in Pathology Central that focus on neoplasia. And this is because this is a topic that will come up again and again as you work your way through the various organ systems. And also having a strong foundation in neoplasia, its pathogenesis, its pathophysiology, will be central for helping you as a future physician. So with that in mind, I will be examining the effects of malignancy on the host, the various paraneoplastic syndromes, and finishing up with a compare and contrast of grading and staging of tumors. So why are tumors bad? How do they harm the patient? There are a number of ways that malignancies can have an impact on a patient. So one category would be local and hormonal effects. So as a tumor grows, it can compress surrounding tissues. So an example of this could be a thoracic tumor that compresses the superior vena cava, leading to what we know as superior vena cava syndrome with edema of the arms and face from patients when they awaken in the morning. We can also get invasion or obstruction of surrounding tissues. An example of this would be obstruction of the common bile duct due to pancreatic adenocarcinoma. And we can also get replacement of tissue by tumor, and as that tissue is destroyed, we can get a loss of function, so hormones or other factors that are typically secreted by that tissue. Now, depending on where the tumor is, we may get surface ulceration. That can be on the skin, for example, a basal cell carcinoma or a squamous cell carcinoma. And with that ulceration, we can get bleeding as well as a risk of infection. We can see this as well in the gastrointestinal tract. So we can have a gastric adenocarcinoma with ulceration causing bleeding, which we can identify on a fecal occult blood specimen. And we can also get the release of hormones, particularly in our well-differentiated tumors. So if you have, for example, an islet cell malignancy, it can be putting out insulin because that's what islet cells do, and this can lead to hypoglycemia. We can also get procoagulants that are released by tumors such as adenocarcinomas. This can cause thrombosis in the patient. Now, there's some other alterations we can see, particularly with our hematopoietic neoplasms. We can get an alteration of immune function that can lead to increased risk of infection. There is another effect we can see, and I'll spend a little more time on that on the next slide, with cancer cachexia or wasting. And then the final one I'd like to talk about is perineoplastic syndromes, and I'll go into those in more detail. But let's turn our attention now to cancer cachexia. So cachexia is defined as a loss of body fat and lean body mass, and it will be associated with weakness, anorexia, and anemia. Now, a lot of patients with a malignancy will have anorexia. And we can see this. This is not actually what leads to cachexia. Cachexia is, we don't know the mechanism. I'll talk about that more in a moment. But it's important to recognize that cachexia is not due to the nutritional demands from the malignancy. As you learn about these various malignancies, you'll see that some are highly proliferative and growing very quickly. But it's not that the tumor is consuming so much energy that the patient loses weight. It's thought actually be due to inflammatory mediators. Now, one thing that we see in cachexia is that typically when food intake decreases, so if a patient is, for example, trying to lose weight and they decrease their food intake, then we're going to see caloric expenditure and basal metabolic rate will decrease in the healthy patient. But in the setting of cancer, we will decrease our food intake, but our calorie expenditure and basal metabolic rate will remain elevated. So that's going to contribute to this loss of body fat and lean body mass. Now, loosely stated, the size and extent of cancer will correlate with the severity of the cachexia. So in patients with small localized tumors, we might not see any cachexia at all. We tend to associate it more with widely disseminated malignancies, but there is no exact quantitation across this. Now, as I mentioned, we don't know the mechanism. It's thought to be due to inflammatory mediators, predominantly a tumor necrosis factor, but also IL-1 and IL-6. Tumor necrosis factor suppresses appetite and also decreases lipoprotein lipase activity, which will prevent the release of free fatty acids, leading to this loss of body fat. And then we also know that inflammatory cytokines have a direct action on skeletal muscle that can contribute to this loss of lean body mass. So the next major topic to consider is paraneoplastic syndromes. So what is a paraneoplastic syndrome? It's a symptom complex that we see in the setting of malignancy that is unrelated to local or distant spread and unrelated to hormones or substances that are typical of the tumor cell of origin. So let me explain what I mean here. So when we talk about local or distant spread, say for example you have a breast cancer that is metastatic to the bone. This is going to cause lysis, osteolysis of that bone, and release of calcium or hypercalcemia. In this instance, this tumor-related osteolysis is not a paraneoplastic syndrome. It is due to distant spread. Another example would be when we talk about hormones or substances that are typical of the tumor of origin. So again, if we were to see hypoglycemia in the setting of an islet cell malignancy, that would not be a paraneoplastic syndrome. But we'll talk about some of the hormones and substances that we do see in paraneoplastic syndromes. So why are paraneoplastic syndromes important? Well, they're fairly common, 10 to 15% of patients with cancer. One of the reasons I think they're so important is because they may be the earliest manifestation of an occult neoplasm. So this can be critical because if you recognize that there's an occult neoplasm, this will speed diagnosis and hasten that patient's appropriate care. Now, another issue with the paraneoplastic syndromes is they may cause significant illness or death. So you need to be aware of this and you can recognize the appropriate treatment for your patient. Paraneoplastic syndromes can mimic metastatic disease. So, for example, the osteolysis that we see in metastatic breast carcinoma to the bone can mimic the hypercalcemia that we're going to see with squamous cell carcinoma of the lung. Now, a really important factor for you to remember is that paraneoplastic syndromes are not specific. So if you have a patient who presents with hypercalcemia, yes, it could be due to a squamous cell carcinoma of lung, or it could be due to a parathyroid adenoma. So you need to consider a broad differential diagnosis when you see something related to a paraneoplastic syndrome. This is so you can recognize a malignancy if that is the cause, or you can find out what the other cause is of that particular symptom complex. So what causes our paraneoplastic syndromes? So here are 4 examples. So we can get elaboration of a hormone or a hormone analog. So the classic example of this will be small cell carcinoma of lung can release antidiuretic hormone, leading to the syndrome of inappropriate antidiuretic hormone release, or SIADH. So if you have a patient who's presenting with antidiuretic hormone excess, then you can look to see if they might have a small cell carcinoma. We can also get a paraneoplastic syndrome as a cancer-induced immunologic response to a normal tissue. So for example, thymic carcinomas can lead to myasthenia gravis. Now we don't know the mechanism behind this. Is it because of some sort of ectopic antigen expression, or could it be due to a T-cell response or cross-reacting antibodies? Another cause of these paraneoplastic syndromes may be the elaboration of growth factors. So for example, gastric carcinoma can release growth factors that will lead to Acrothosis Nigrocans. And I'm going to show you an example of that in a moment. And then I alluded to this earlier, the release of tumor products. So pancreatic carcinoma can result in superficial thrombophlebitis or Trousseau syndrome. So this is a table from Robbins and Kumar Basic Pathology. Don't focus on it. The print is very small. It can be a little bit overwhelming, although I do actually think that this table is something with which you should familiarize yourself. I've made a more concise table in which we have the general category of the paraneoplastic syndrome, so an endocrinopathy or something affecting nerve and muscle or dermatologic. I then have in parentheses what is being released. We'll talk about this in a little bit more detail. And then I have here in bold print the entities that are most commonly associated with this particular paraneoplastic syndrome. So Cushing syndrome, which we'll talk about in a moment, is associated with small cell carcinoma of lung. I've already mentioned hypercalcemia with squamous cell carcinoma of lung, and myasthenia associated with thymoma. And then the third treasure that you can get from this is that I've highlighted in yellow the most common paraneoplastic syndromes. So these are ones that you're going to want to keep an eye out for. And these are actually covered in additional videos in the Pathology Central series. So when I talk about valvular vegetations, there's some commentary on non-bacterial thrombotic endocarditis. And there's a discussion of Cushing syndrome in the adrenocortical dysfunction video. So a lot of these will be covered in additional videos. So let's begin first by looking at hypercalcemia. So I already said that you could see hypercalcemia in the setting of osseous metastases and that is not considered a paraneoplastic syndrome. So what type of hypercalcemia is a paraneoplastic syndrome? Well, it's very interesting, but you can get tumors that will release a parathyroid hormone-related protein, or PTHrP, which has structural homology to parathyroid hormone and therefore has a similar series of actions. Increased bone resorption, which will lead to hypercalcemia. We also will increase our renal calcium uptake and decrease our renal phosphate transport. So this is all going to lead to hypercalcemia. Now, why do we see this? PTHrP is produced typically in small amounts by many normal tissues, for example, keratinocytes. So when we see carcinomas of the lung, particularly our squamous cell carcinoma, these are going to be keratinocytes. This is going to be where our PTHrP comes from. Now, we can also see hypercalcemia due to PTHrP from breast carcinoma, and keep in mind that breast will frequently go to bone, so that hypercalcemia may be particularly elevated in individuals with metastatic breast carcinoma because of the combination of the perineoplastic syndrome plus those osteolytic metastases. We can also see it with malignancies of the kidney or ovary. So what this tells you again is that, typically for your boards, you're going to learn, the most common. So you'll, be really focused on squamous cell carcinoma of lung and hypercalcemia. But as a practicing physician, you need to open your mind to the other possibilities as well, because this will help you to make the correct diagnosis for your patient and provide that optimal patient care. Now, the next paraneoplastic syndrome I want to look at is also an endocrinopathy. This is Cushing syndrome. Now, as I mentioned, I have a video which addresses adrenocortical dysfunction, so please take a look at that one. I want to provide sufficient background on Cushing syndrome so that you're not just memorizing, small cell carcinoma of the lung, Cushing syndrome, and moving on. Let's have an understanding of what we're going to see. So when we get paraneoplastic Cushing syndrome, about half of the time it's going to be due to small cell carcinoma of the lung. And actually, small cell carcinoma of the lung is associated with a variety of paraneoplastic syndromes. And what Cushing syndrome is due to is going to be excess adrenocorticotropic hormone, ACTH, or a corticotropin-like peptide. And what this ACTH is going to do is it's going to have a profound effect on the body, because ACTH is a very powerful hormone. So what you might see in a patient is they can present with weight gain, which is characterized by truncal obesity, what we call moon facies, as well as fat deposition of the posterior neck and upper back. And I'm going to show you an image of this on the next slide. Patients may present with weakness, proximal limb weakness, or symptoms related to diabetes, because ACTH will increase gluconeogenesis and decrease glucose uptake into cells, leading to hyperglycemia, glucosuria, and polydipsia. And then another finding we see in Cushing syndrome are catabolic effects. So we get loss of collagen and bone resorption. These can lead to easy bruising, delayed wound healing, and cutaneous striae in the case of collagen loss, as well as osteoporosis in bone resorption. So let's take a look at some of these findings. If this patient presents to you and you see you have moon facies, truncal obesity, and striae, you may be thinking that this is going to be a Cushing syndrome. So the question would be, is this related to the adrenal pituitary axis, or could this be a paraneoplastic syndrome? So keep that in mind as you're evaluating your patients. Now, the next paraneoplastic syndrome I want to address, because it's particularly important, is Acrothosis Nigrocans. So why is this important? Why am I already spending the time on this? Because if you have an adult patient over the age of 40 and they present with this Acrothosis Nigrocans, which is characterized by gray, black to hyperpigmented patches of velvety, thickened, hyperkeratotic skin, 50% of them will have cancer, usually a gastric carcinoma. Now, as I've mentioned before, these paraneoplastic syndromes are not specific. So you can also see Acrothosis Nigrocans in the setting of diabetes or metabolic syndrome. But if you have a patient who has diabetes and Acrothosis Nigrocans, think about the possibility of a gastric carcinoma so you don't delay diagnosis. Now, occasionally what you'll see with Acrothosis Nigrocans in the setting of a malignancy is you will get the abrupt appearance of multiple seborrheic keratoses. And I'll show you an image of that in a moment. Seborrheic keratoses are covered in the skin chapter of Robbins. They are basically small hyperpigmented patches that appear on the skin. So let's take a look first at our histology here. I typically put the histology after the clinical images, but I had the appropriate size space to slot this in. Look at this hyperkeratosis. Look how thickened that stratum corneum is. This is due to the secretion of growth factors. So let's take a look here at what we can see clinically. You can appreciate here we have two patches, both in the axilla, this hyperpigmented skin. Sometimes we can actually see papillary excrescences because of this hyperkeratosis. And then just to finish up the discussion, the sign of lesser trala. This is an individual who presented with carcinoma of the breast. You can see she's had bilateral mastectomies, and shortly after diagnosis had the sudden appearance of multiple seborrheic keratoses. These are more commonly seen in older adults. They appear to be pasted on lesions. And for this particular patient, these lesions are benign, but because they can ulcerate and bleed, you can get an increased risk of infection. So she had ablation, and you can see that there. And then the final paraneoplastic syndrome I want to address is hypertrophic osteoarthropathy. So why do I want to talk about this? Because I really don't think Robbins goes into sufficient detail on this for you to understand this as a first or second year medical student. So we see hypertrophic osteoarthropathy in about 1 to 10% of patients with carcinoma of the lung. And this particular paraneoplastic syndrome is characterized by three factors. We can get periosteal new bone formation, which typically is going to affect the distal ends of the long bones, and the metatarsals, metacarpals, and proximal phalanges. And because of this periosteal new bone formation, we can get arthritis of the adjacent joints. So a patient may present with knee pain, for example, such as this patient. An X-ray is done, and you can see here this periosteal new bone formation. Now, this is very characteristic of hypertrophic osteoarthropathy. By contrast, clumping of the digits, which you can see an example of here, where you tend to have this bulbous sort of appearance of the distal digits and this convexity of the nail. This can be seen in many different entities. So liver disease, diffuse lung disease, congenital cyanotic heart disease. This image is also shown in one of those videos, ulcerative colitis, and more. So this is much more specific, the periosteal new bone formation. This can have a variety of different causes, and we don't know the mechanism for this. So these are just some of the paraneoplastic syndromes that I thought warranted a little bit more discussion. I'd like to now turn to grading versus staging. So the whole point of grading and staging of tumors is to predict clinical aggressiveness. And why do we need to do this? Because this is going to let us know the patient's prognosis or give us some idea of their prognosis. And patients would like to know their prognosis, but also being aware of that prognosis can help drive the therapeutic plan. If someone has a very aggressive malignancy, they may wish to have more systemic chemotherapy. They may wish to be more aggressive with their treatment. Whereas if something is a low-grade lesion and only grows slowly, maybe no intervention is necessary. So a classic example of this would be prostatic adenocarcinoma. So if you have a low-grade prostatic adenocarcinoma, sometimes we will recommend no therapy, but rather just surveillance, close surveillance, with the idea being that sometimes the treatment is worse than the disease. So the two ways that we assess clinical aggressiveness are going to be grading and staging. So grading is something that we do as pathologists. It involves histologic evaluation of the tumor. And what we do is we look through a microscope at every malignancy that we receive, and we will give it a grade. Now, you don't need to be concerned at this point in your career with all the different grading systems. There can be a 2-grade system where we say low versus high. That largely has to do with when we have dichotomous therapy. So either surgery, no surgery. So if it's low grade, no surgery, high grade surgery. If there's nothing in between, there's really no need to go into more grades. Typically, we will have 3 grades where we have well differentiated or grade 1, moderately differentiated or grade 2, and poorly differentiated or grade 3. And the way that we determine differentiation is going to be looking at some of the features that I discussed in the video on features of malignancy. So how rapidly is this tumor growing? Well, the way we know this is we look to see what the mitotic activity is, and we look to see if there's tumor necrosis, because this suggests that the tumor is outgrowing its blood supply. We also will look at architectural features. So well-differentiated tumors tend to mimic the architectural features of the cell of origin, so they may have well-formed glands, whereas a poorly differentiated tumor may just be sheets of cells that are very difficult to recognize. And there are other factors as well. So grading is a pathologic histology microscopic examination. Staging is going to be a combination of your clinical, your radiologic, and your pathologic evaluation. So the system that is used most widely in the United States is the AJCC system, which is the American Joint Committee on Cancer Staging. And this is referred to as the TNM system. T stands for tumor, N for nodes, M for metastases. So T is going to correspond to the size of the primary lesion. Now I put that in quotes because it will vary based on the type of malignancy. So different sizes have different cutoffs for elevation and stage depending on the malignancy. And sometimes it's not the exact size, but it can be depth of invasion. So if you're looking at a malignancy in the gastrointestinal tract, you're not interested necessarily in whether it's 7 centimeters or 12 centimeters. You're interested in how deeply it is invading into the gastrointestinal wall. Now for other organ systems, like if you look at osteosarcoma, size will be size. How big is it? Is it 5 centimeters, 10 centimeters, etc.? Lymph node spread is pretty self-evident, but again, it will vary. Sometimes the staging will say 0 to 1 lymph nodes, or 0 to 5, or 3 to 7. There are varieties, and this is all done using data, epidemiologic data, looking and correlating these various parameters with survival. And then metastases, typically we'll be looking here. Once you have distant metastases, that will be stage 4. And this is going to indicate to the clinician that systemic therapy will be necessary because you cannot simply eradicate the tumor using surgery or radiation. So that is how staging comes into play when we're talking about our therapeutic plan. Now, something to keep in mind is that while both of these are used to predict clinical aggressiveness, once we have a staging system and we're looking at the stage, this is going to tell us much more than grade will. Grade can be useful if you have, say, for example, a small tumor and you biopsy it. If you have 2 patients, one with a grade 1 tumor, one with a grade 3 tumor, you will expect the grade 3 tumor to be more aggressive. Once we have metastases, we have a certain size, that's going to give us a lot more information about that patient, their prognosis, and the aggressiveness of that lesion. And then before I finish up the discussion, I have to mention that while we traditionally have used size, lymph node spread, and metastases, we are increasingly using molecular classification as we learn more about different subtypes and correlate that with prognosis. So just to finish up, here are some questions so you can assess your learning over the last 20 minutes or so. And as always, thank you very much for your time and attention. I hope you have found this useful.